Emergency Medical Minute presents Mental Health Monthly. Substance-induced psychosis, the agitated geriatric patient, manic episodes. Paramedics, nurses, mid-level providers, and physicians in the ED all regularly have to manage patients with psychiatric conditions, often with limited training and resources. In this series, psychiatric experts keep it real, raw, and relevant about what you need to know to successfully care for these patients in an emergency setting.
Hello, welcome to Emergency Medical Minute. This is our spin-off series, Mental Health Monthly, and I'm Dr. Travis Barlock. In the last episode, Dr. Andrew White and I discussed the initial approach to the psychotic patient in the emergency department. In this episode, we're going to discuss mental health holds, psychiatric placement, pharmacologic versus non-pharmacologic treatments, and outpatient care of psychotic patients. I hope you enjoy. Now we've in this camp now of the patient's been medically cleared. Now what? And so one thing that I've thought about and I want to just get your thoughts on is who are the patients that we need to recognize as being a threat to themselves or others and will need to be placed on a mental health hold. Because beforehand, you could kind of say that this patient might need to be on a medical hold. They have psychosis and are not medically cleared yet. And so if we're thinking that this is truly psychiatric in nature, primarily, who are the patients that you think meet criteria to truly be on, an M1 hold?
Oh, that's a fun one. That is a fun one. I was just hoping we could put him on a medical hold.
Just the whole time.
The whole time. No, and this is a great question, right? Because I think anyone in our lines of work grapples with this question. So maybe for anyone that doesn't know, when we talk about M1 holds here in Colorado, these are our equivalent of a psychiatric certification for 72 hours. I'd like to approach holds on a case-by-case basis because, frankly, anything else leads to basically more of just a kind of CYA, like we're just going to put everyone on a hold, and that works until you try to send them somewhere for treatment, and then there's just no beds anywhere. So I think if you're going to do a hold, you need to be willing to have a conversation with a person to really talk about what their current safety risk is. When I look at 2765, the legislation around our ability to put on these holds, it talks about there needing to be I think A is like this is mental health etiology. So we're at that point. I think, as you said, the only reason I like to lean into that is because sometimes folks will have a hold for all sorts of reasons. The next important word that I look at is this imminent idea, right? So it's not just that you're a danger to yourself or you're a danger to others, but this is an imminent thing. When I do that math in my head, I mean the next 24 hours. So that's the metric that I use to really engage in a conversation with someone about what their current concerns are. Because usually, as you can imagine, someone coming to me to see if they need to have a hold on them is probably said something that scared someone else to the point that they thought like, oh, it's my job, but it's like, oh, you need to go see a psychiatrist. You need to go like something's going on in your head. And I think the less you treat someone who's going through maybe the worst day that they've had in a while, like they're losing it, I think you start to evaluate, I kind of break things down into what are their chronic risk factors for suicide risk and what are their immediate things. So chronically, right, it's all the stuff we learned in med school, the like old, lonely white dude who's got guns and wife died or something, right? And he drinks alcohol, right? Makes it even more high risk. But all of those things that have kind of been there, not just in the last 24 hours, but the months leading up to it. So if you can convince yourself that whatever risks have existed are not dramatically changed in the last 24 hours, there's not some crisis going on, this person didn't prepare by writing letters that they're going to kill themselves or have really concerning behavior, then I think the only other thing that I do is I look at collateral information and try to make sure that what you're hearing from the patient is corroborated by people around this person. So you kind of do that with danger to self, you do it with any concerns about other folks, like if they've been saying, oh, I'm going to kill someone, I do think it's an important point to note that we do have a responsibility to let folks know, the duty to warn if that comes up. And then Colorado has a very interesting little segment of our mental health holds around grave disability, which, do you get into that at all? Do you put holds on for?
Yeah, that is, I think, harder to summarize really easily. It seems like it's kind of a subjective assessment. It's,
It's like a catch-all. It's if the other two things don't apply, but I still am worried about you.
Right. It's hard. I think you just need to be able to articulate that.
Yeah.
You need to be able to explain why you really think that this patient is gravely disabled from their condition, even if they're not. I think the question that we ask to see should we put this patient on a hold is, are they suicidal or are they homicidal? That's almost like the question. But then from there, it is, as you say, there are these other aspects to it, and for better or for worse, it seems like the spirit of it is well intended. If a patient is gravely disabled from their psychiatric condition, they probably shouldn't go back out into the world until they've been fully evaluated and treated. But yeah, I think that term gravely disabled was going to mean different things to different providers, and it kind of harkens back to honestly what you kind of said at the very beginning of this, which is your gut. It's there's just something telling you that this patient is it's worrisome, and
Yeah.
because but then you have to, I think, go beyond that and say, how is this person going to actually function in the world? Can they take care of themselves? Are they able to go to the doctor's office? Are they able to manage their activities of daily living? And I think if you can medically reason that they can't because of their condition, then you're probably in that camp where they probably should be on an M1 hold.
Yeah, in the way I look at it too, right, is where when we talk about this M1 hold, it takes away someone's rights and their freedoms, right? So I don't think we should do it just kind of willy-nilly, but at the same time, I think we do that because we're setting people up with treatment, right? It's not just we're giving you this M1 hold and then you're in timeout for 72 hours,
right,
and then we're going to certify you for another 90 days and all the things that people talk about. But what I think is important, and this is kind of your point too, right? So in this evaluation process, if someone's medically cleared with their psychosis and they come to us and maybe they're hearing voices or they feel like they're being told by voices that are going to harm themselves, right? All of those things become sort of the new focus, which is how do we both decide what's the best way to treat this? Because psychosis in the general experience that I've had in the emergency setting for psychiatry can be folks crashing from substances, folks from a mood with psychosis picture. So people think mania or major depression with psychosis, or more of a primary psychotic, schizophrenia, schizoaffective thing. But all of those aspects, as we're looking towards our overall approach, right? It's let's treat it. Let's treat this now. A lot of the folks who come in through the emergency services in a psychotic state will probably leave within 24 hours feeling better, having cleared. What's hard is someone who comes in and looks gravely disabled because of their psychosis and unable to even reason what's going on. If given some TLC and some Zyprexa, can feel pretty good the next morning.
Well, let's now use that to talk about, I guess, what really does happen, after one of these patients gets placed. So a patient we identify has no medical etiology for their psychosis. Let's say they do require an M1 hold and they require placement to inpatient psych. So what then happens next?
Yeah, so it's choose your own adventure, right? The patient really gets to pick how the next 3 to 5 days plays out. Traditionally speaking, upon being evaluated and seen as psychotic by a couple of providers, there'll be an antipsychotic started. Usually folks go towards some of the second generation antipsychotics, depending on what a patient's history is and their risk factors. But if they don't have any metabolic risks and any concerns there, someone's probably going to get started on a fair amount of Zyprexa. We like to use that preferentially because there's a Zytis form of it, which is like an orally disintegrating tablet. So if you have someone whose compliance might be a little questionable, you can, just give them a little dissolvable pill. They don't even have to think about swallowing it.
What are the doses that you're using?
It depends on how aggressive I'm feeling that day and what I'm seeing, but I would say anywhere between 2.5 to 5 at a given dose. Like that would be my starter dose.
And this is all ODT?
Mm-hmm.
Okay.
Yeah. So this is presuming, as you're insinuating, right, that someone's taking the meds and agreeing. I think that is definitely something that some people do.
What if you have the other case where it's someone who's a little less agreeable?
Yeah, well, a little hot tamale comes up to the unit. Those folks generally, if they're not posing a harm to the milieu and the environment, you don't have to be medicated when you're psychotic. There are many people right now in this world walking around psychotic, not causing any issues. But typically, just given the way things work out, issues happen, and folks will probably end up getting medicated against their will, which is just kind of, like being restrained and given whatever medication that the on-call doc decides that day. And that's a culture thing. I think where I practice, it's usually a Haldol, maybe some Benadryl or Ativan. Some people do all three. There's no evidence that shows adding all of it at once does any better than just like 5 of Haldol and 2 of Ativan.
Okay.
But that's kind of my go-to because nurses can draw them up, put them in the same syringe, and it's an easier, practical thing to ask someone to do in the heat of the moment.
Okay.
Yeah, so those are folks, once that happens, technically a process called emergency medications are started. So if someone's getting medications against their will, every 24 hours, you have to certify or write a note of why you think this person needs these medications against their will. Yep. And so those are continued if they're needed. If people say, I think a type of people that we haven't explained up at this point would be like psychotic people who just sit in a chair and chill, but are not eating or drinking or, not taking care of themselves.
It's almost like the extreme negative symptoms, just to the max.
Yeah, you can't wait till old Uncle Joe who's sitting there in the chair pops off because he's never going to pop off. So those folks end up after the end of their 72-hour hold getting a certification applied for. And so the treatment team will write a letter to the courts and they say, we want this person to be here for 90 days. And during that time, we want involuntary medications.
I see. I think that's also a good example of the grave disability.
Yeah.
That might not be the person who is overtly stating suicidality, homicidality, or anything like that, but clearly it's a patient who is gravely disabled.
In fact, they'll say, I'm not a danger to myself or others.
Right.
Oh, you know the game.
And that's probably true.
Yeah, I respect that.
Yeah, right.
Touché.
But they are a danger to themselves. But it's just not in the same way that we usually think of it.
Yeah, and I think that hits the biggest point of all of this, right? Where do they go from the ED to the inpatient or even to the outpatient side is when we think about psychosis from a mental health side, it's really we got to save this brain. Every episode of psychosis is burning away that beautiful brain that you have. And I think folks, if we look at what works best after this, going to the inpatient unit, getting started on some meds, there's a couple of key points, right? One is let's try to get you started on a med that has a long-acting injectable. So a lot of these folks, we try to get you on an Abilify or we try to get you on a risperidone because we can then give you a 30-day shot of that. That will help. And the more aggressive we treat the psychosis and the sooner, the better people do.
What about non-pharmacologic treatment? I mean, we've been talking a lot about, antipsychotics and whatnot, but I would imagine that it's an adjunct to other things like, I mean, what's the role of family, of cognitive behavioral therapy, and other kinds of things, I guess, non-pharm.
Yeah, the hippy dippy stuff. you optimist.
Yeah, I don't know what am I even thinking?
What if we involve the families with these people? No, yeah. Mental illness is a family thing. Serious mental illness, if we can differentiate those, like a schizophrenia or these primary psychotic stuff, it does. It affects everyone around these individuals, mainly because the name of the game for a lot of these folks is it really is, if we're trying to save their brain, I think the parallel to that in the day-to-day functioning is like we're really trying to preserve the things you're doing at this point.
Mm-hmm.
Understanding that in that lens, that disease model, that this is a chronic progressive thing. So folks do need PT, OT support. They need family guidance. One of the great organizations around the U.S. is NAMI. It's like the National Alliance of Mental Illness. They provide family-to-family groups and resources for, honestly, the things that if you're not raising a kid with schizophrenia, no one else is really going to understand what you're going through. But the social supports are huge. In the psychotherapy realm, one of my favorite psychotherapists, Harry Stack Sullivan, he has done some therapy in the past with folks with psychosis, and I think it's interesting to read his takes on it. I don't know if it ever got to a point where I would say I recommend it for folks. Intellectually, I think it's curious, but even with us talking about psychosis as outsiders who are not psychotic at this moment, it's kind of voyeuristic, right? Doing therapy with someone who may not understand exactly what's going on may not actually benefit them as much as you think. So there's not a lot of work that shows anything in particular for therapy is where you should put your money. But if you get someone even in CBT or even basic supportive therapy, that relationship is huge.
Yeah.
And psychosis gets better. And the way I look at it is they keep it together until, a med student like you or me asks them a question about that one little thing that they're willing to unravel over.
Yeah, I just imagine that in the bigger picture of, helping one of these patients really just get through the day and get through their life is that the medications are going to be a huge role, but really it's, I just imagine that it really must be having something to anchor, reality and some stability in their life. And that's why, I wondered how big of a role is it with family and social support and things like having a job and having just the routine and regularity and just and having a psychiatrist that they can go to regularly. Just that I would imagine that would be huge.
Yeah. And the only way I would spin it back to you is I think the things you describe, if all of us did them, all of our mental health.
Yeah, it's just more of a general thing about people.
If we got some rest, and we had a better diet and exercise, and our job paid us what we deserve. But to your point, right? I think that the way I look at it is sort of derived from this idea in sociology about positive deviance. We're all given the same environment, but what makes those among us who do well or thrive different? Yeah, there are folks with schizophrenia who are musicians, they're physicians. People can have a primary psychotic disorder and maintain life. I think the reality is you have to be intentional about it, like you're saying, right? You have to, you're scared and don't trust people, and your psychosis is rooted in paranoia. Okay, let's get you a job. Yeah. Let's do it.
Yeah, right. Gosh, it must be daunting, but also it is kind of what's needed. Maybe we can touch briefly on what outpatient care and how you approach psychosis in the outpatient setting, what that's kind of like, and we can probably wrap this up.
Yeah. I think the big points there that I would share with folks is, psychosis is not like a death sentence. a lot of folks who will have, oh, put it this way, right? Like one of the stats that I always use with some of the kiddos that I work with, they're like teenagers. It's around auditory hallucinations. It was like this study in, I think it was New Zealand, and they found that like about 25% of folks heard voices. I just heard voices at some point on a year-long sample. And so sometimes I think just as we're tasked with being like reality testers for folks with psychosis, we also can be a voice of reason to say like, yeah, you had some psychotic-y stuff going on. But even like the language of like psychosis, it implies a psycho, like it sort of has a lot of stigma that my work as an outpatient doc becomes to contextualize what folks went through, because many people who have, a brief psychotic episode, they're not going to go on to schizophrenia. Like something happened in their lives, this mental breakdown of sorts occurs. And so I like to adapt whatever language best makes sense for their history, try to give them diagnostic clarity, because then the name of the game becomes, how do we prevent, how do we anticipate what's going to happen? What's the prognosis for this? Mm-hmm. If you've got someone who's withdrawing from school, they've got positive symptoms of schizophrenia, and you're there like month after month getting worse, like, yeah, get aggressive. Mm-hmm. Get really aggressive and then implement some of those supports that you mentioned, right? Like we got to build up support around this individual. For some of the older folks and people I work with, once they've had, established schizophrenia and working through, I think it becomes a constant battle of avoiding side effects from medications.
Sure.
These antipsychotics have all the extrapyramidal stuff that we learn about and the metabolic stuff. And they're just, they're pretty sedating meds, really anticholinergic, like they kind of knock you out. And so when folks talk to me about feeling like a zombie on certain meds, these are the ones that I worry about, because, again, outpatient psychosis treatment is a marathon, and you just try to keep up and keep the pace of the person you're working with, understanding that, one of the best studies we have in schizophrenia is this thing called the Katie trial. It was back in the early 2000s. And they had all these folks, and they're really looking at like atypical versus typical antipsychotics, like which is tolerated better, who does better on these. But the big take home at the end of the year or so of treatment that they were in is that only about 25% of people were on those medications still.
Oh, really?
Yeah.
Okay.
And so it really wasn't there wasn't a big difference between the two. We have a lot of our evidence about like olanzapine causing more weight gain because of that study. But you can't, don't miss the big picture.
Yeah.
Splitting hairs about meds may be less important than engaging folks who, by the very nature, right, we've talked about it all day, are tough to engage with. Mm-hmm. They're not in the reality that we're in, but I think we can meet folks where they are, or we can continue to isolate them and be like, oh, this is what happens when people get psychotic. It's like, yeah, that's like psychosis is the limits of what brains do.
Wow. Well, I think that right there, that's a great spot to end it.
We've reached the limit of our brains.
I think we have. I thought this was a really interesting conversation. I hope that listeners might have a little bit more comfort with the topic and have a little bit of a diagnostic approach to it, and have a little bit more also insight on kind of what happens after patients, leave the emergency department and are hospitalized and then are back out in the world. Dr. Andrew White, thank you so much for coming on to the podcast.
Dr. Travis Barlock.
It's weird to say,
a pleasure.
Right? Yeah. All right. Thanks,
Thanks
man.
for having me.
Appreciate it.